Good evening, dear audience. Welcome to another session of our educational series. And today we have chosen a topic which is of great concern to patients, parents, children, and doctors. Yes, I am talking about childhood myopia. And in order to discuss this topic, we have requested once again Dr. Carla Lanka. Dr. Carla Lanka is an associate research fellow in New York University, Abu Dhabi. She has done graduation in orthoptics and PhD in public health. Apart from this, she is a fellow of Singapore Eye Research Institute. She has extensive experience in management, research, and education about visual sciences. Her special fields of interest are myopia, binocular vision, and strabismus. We are thankful to her that in spite of her very busy schedule, she has accepted our invitation once again to explain this topic about its management, causes, and how it can be prevented. So without further delay, I will request Dr. Karla Lanka from New York University, Abu Dhabi to please present her talk.
Thank you so much for the lovely introduction and for the invitation to be here today to present on risk factors and monitoring in myopia. So today I prepared a presentation. This is just my conflict of interest. I tried to make the presentation simple so to be helpful for clinicians who want to start myopia management and to understand some of the risk factors and how we can monitor myopia. So just to start a bit about definitions, for many years we were looking at myopia as only a refractive error. And as you can see here from this imagery, when we see a progression from an emmetropic eye to a myopic eye, you can see that 0.5 diopters, which is the international definition for the International Myopia Institute, where we consider an eye as having myopia. But you can see if you look into the right part of this imaging, that the eye starts to elongate. And what we want to prevent in many of these children is that they reach this stage of high myopia, that in some studies is defined as -5 and others as -6, which -6 being the one used by the International Myopia Institute. And why do we want to prevent high myopia? If you look at this image at the far right, you can see that this eye is very elongated and there is the risk of developing severe pathology. And we are talking about pathological myopia, and I will show some images of how severe this disease can be. A bit of myopia prevalence, just to give an idea how myopia is evolving. So we know that is a major public health problem. There are several reports showing that the prevalence is rising in youth. There is a recent study showing that in 10 years from, for example, 2000 to 2023, there was an increase in about 10% from 24% to almost 36%. We also have several studies, one of the most important published by Holden et al., saying that myopia prevalence in global prevalence in the world will reach 50%. There are more recent studies showing more conservative estimatives, but nevertheless, the most conservative is around 40%. So it's still a huge problem in terms of public health. But you can also see from this graph that I'm showing here from a recent publication from our group that there are regional differences. So not all countries have myopia prevalence high, and there are differences. So you can see here, for example, Oceania and Africa, they have very low prevalence, or Latin America. But then when we start looking at Asia, you can see that there is a strike and huge difference compared to Europe, North America, for example. And why do we want to start intervening very early? So the reason is when we have a child with myopia, and this is a very early onset, then we know that there is a risk of faster progression. If they progress faster, they will reach high myopia earlier than we want. So in another thing is when they reach this level of high myopia, then we know that several visual impairment diseases can occur. For example, you can see from these images where I'm showing myopic maculopathy or myopic degeneration with several levels of severity, as you can see from the images. We can also have retinal detachment, and we can also have glaucoma. So we know that this risk increases in high myopes, but we also know that there's no safe levels. So even for low myopes, this can also occur, although the risk is lower. And we know from studies from Bullimore and Brennan that for each 1 diopter additional of myopia, the risk of myopic maculopathy increased by 67%. So what we really want is to start intervention very early because we want to prevent severe disease. So this is the stage that we want to avoid. We also know from recent studies that we're looking into, for example, if we use environmental factors such as outdoor time, can we prevent myopia to develop? And yes, we can. And this happens if we are talking about emmetropic child. But when we are talking about children that already have myopia or they are in a pre-myopic state, then this is much difficult to achieve. So again, the importance of preventing the disease. So in terms of risk factors, they are very well known, but just a brief overview of how in the clinic we can manage them. Because I divided them into groups. So we have the non-modifiable, and this means that the patient has it and we cannot modify it. The age, we are talking about a younger age. The sex, some studies say female gender have more risk to development myopia. We have ethnicity, Asian ethnicity, and of course, genetics. So those we cannot change. But however, in the clinic, what we can do is to identify them and then stratify the child that we have for the risk. And based on the risk, we can decide how to make our intervention. Then we have the ones that we can really modify and are related with the lifestyle. So outdoor time, it's very important. If the child that we have in our clinic has a very low exposure to outdoor time, is doing a lot of neo work, and in a relation with neo work is also doing a lot of screen time. These are things that we can recommend for the parents to try to avoid or change the lifestyle. So there's something that we can do to try to manage those risk factors. So in terms of initial consultation, what to do when we have a patient with myopia or at risk of developing myopia. So you can see here from the Brian Vision Holden Institute what we should do in terms of assessment is a very simple assessment or normal regular assessment in ophthalmology. The most important one would be to have a proper refraction. And when I'm talking about a proper refraction, it should be with cycloplegia, at least the first assessment of refraction for us to have an accurate diagnosis of myopia. And if possible, measurements of AL are very important. I will explain later during my presentation the research that has been published supporting the use of AL as well. And of course, do your lifestyle assessment. This is also very important in terms of clinical approach. Another thing that I want to highlight in the assessment of those children that have myopia is that we have this idea that most of myopia is environmental. And sometimes even me that I'm talking a lot of environmental risk factors have to stop and think that some of these myopic cases, they may be syndromic. So it's very important also to assess other factors. For example, when we have a child that has a very young age and a very high myopia, then this might be a red flag. So we need to assess other factors. We need to go deeper in the family history to try to understand if there is something that may suggest some syndromic anomaly. We also need to search on our ocular exam for other factors, look very well to the retina, an OCT, or any other testing that may prompt you to do this investigation. It could be a keratoconus, so it could be a number of several different things that may need investigation. So I like this slide from the Brian Vision Holden Institute, because this, after you have all your examination done, then you can divide your intervention based on what you found. So one of the things that you may found is that you have a child that does not have myopia, but there is an increased risk. So you assess either the lifestyle, the presence of myopia in the parents, and you are concerned that even if myopia is not present now, it can be in the future. And the other group is those children that already have myopia. So you know that they have the risk of progression, and those are the ones that you have to target for treatment. We can discuss later what to do with this increased risk, because there's a big discussion on whether we should intervene now or later. But now I want to really focus on this child that is sitting in front of you, a child with 8 or 10 years of age. You can see that there is a high risk of progression. You measure AL and you see that it's longer for the expected growth for this age. You have both parents with myopia in front of you. They are of East Asian ethnicity. So what to do? So of course, start with a myopia control management to slow the progression, and of course to try to reduce the risk of pathology that I was talking early on my talk. There are many options. I think the aim of my talk is not to discuss all the options in terms of management, but of course you can choose low dose atropine, you can choose optical strategies, ortho-K, myopia control spectacle lenses. You can also, of course, advise on lifestyle and behavioral measures, such as increasing outdoor to about 2 hours per day, reduce near work, screen time. And there's also a lot of emergent technologies, such as red light, that can be used, other technologies such as AI-based risk stratification, and new optical designs that continue to appear in terms of options. So our group has been done quite a lot of work on several of these options available. And of course, this is just some examples of some of the options that you have to slow myopia progression. And they have been shown to be effective, which is the most important in terms of selection. The option to select, I think it will depend a lot, not only of the efficacy, but also the parents, the compliance, and the lifestyle of the child. So another thing that I want to really highlight is the importance of AL. More and more research studies are showing that measuring AL is important. For example, this study that I show here, you can see the actual length in the y-axis, and on the x-axis, you can see the levels of myopic maculopathy. And as you can see, as the AL increases, also the levels of severity of this disease also increase. So it gives us an idea of the risk of developing severe retinal disease, as you can see from this publication. Of course, there are more. Another question that you may have is how frequently I need to see the child. Of course, there's no research study that has shown which is the best monitoring schedule, and this may depend on the child, may depend on your practice, it may also depend on how confident you are with the method that you are using for this particular child. But we can talk about some intervals. For example, if it's a very low risk child, you may just see once per year. If you see that the risk is moderate, maybe 2 times per year. Very high risk or on very specific treatments, such as contact lenses, red light, for example, or orthokeratology, you may need to see them every 3 months, for example, or in the beginning, more times. until you settle that contact lenses are okay and the method is working the way you want it to be. Of course, the frequency of follow-up may also be needed to adjust it according to the age and the progression. So talking about how to interpret progression, and if there is a big discussion on how we can do this, I think we are still evolving in terms of research and in terms of what methods we have available to evaluate progression. So there are a lot of centile charts that have been provided by different groups around the world for Asian populations and for European populations or Western population as well. A recent study by Mark Bullimore and Noel Brennan discussed the use of these centile curves. And they found that because they include myopes and also emmetropes, they might not be the best to use in terms of controlling progression. So they are advising us to use annualized growth rates. So in this graph, which I computed with the values from this paper, so the graph is not original from the paper, but the values were calculated based on the equations that the authors provide. So you can see here, I plotted two curves. I plotted myopes. So this is myopes, okay? Expected growth in myopes. So in green, we can see East Asian ethnicity. And in orange, we can see the non-East Asian. So as you can see, the growth is much higher in East Asians. And I also added this gray area of rapid growth. So you can see from 6 to 8, or if you want until 9 or 10, there is a very rapid growth and then starts to decline until we reach 18 years of age. But this is not enough. We are just looking into myopes. So many groups in the world are now also looking into how the normal growth happens in an emmetropic eye. And many are advising that we should also look into our aim in terms of control should be the emmetropic growth. So what I did was from this paper, from Fabian et al., where they looked into the emmetropic growth, I did the same. So I went to the study, took the values, and plotted the curves. So on the top, you can see the actual length, and then you can see the curve of how the actual length evolves with age. And on the bottom, I plotted the normal growth, if you want. And you can see by age. For example, you can see for a child of 6 years old is about 0.24, and it starts declining until it reached 16. I didn't plot 18, but of course it's going almost to zero with age. So I think this can be really helpful if you have your patient, and then you can also mark in the graph where your patient is, and you can do over time to see if the growth is stabilizing or if it's continuing or decreasing. Over here, I superimpose both of the data. So you can see myopes, you can see the emmetropes in the bottom, and also the areas of rapid growth and then the deceleration that starts between 12 and 16. Another thing that I would like to highlight that, of course, we are always monitoring the child and we want the growth to be reduced. But this does not mean that there is a zero growth because the eye is still growing until a young adult age. So we need to have that in consideration. But if something doesn't look right, for example, if you see that there is a spike in progression, even on treatment, I would say that the first thing I would do is to assess the compliance and adherence. Try to understand if that child is adhering to the treatment or not. And of course, in the situations where you already stopped the treatment and you are just evaluating for rebound, it is very important to continue to evaluate this rebound. And if you see that there is an increase, then studies like the LAMP study are showing if you stop atropine, you can then retreat those children if there is this rebound effect. And when you assess the treatment adherence and you find that it's good, the child is adhering, but still with the method that you choose, there is still progression or progression is escalating, then what we can do and what we have available at this moment, you can combine treatments. So that's another option that can be used for higher risk patients. So I'm almost reaching the end of my presentation, but there is one topic that I would like to talk about is that many studies are trying to understand if we can use biomarkers for monitoring treatment. So there are very interesting studies focused on choroidal thickness, as this one, as you can see from multifocal contact lenses. So those authors, they found that that choroidal thickness, choroidal was thickening 2 weeks after the treatment, and this persisted over 3 years. So they found that there was a link between this and the growth, the eye growth that was slower. However, there's something that is important, and we need, of course, more studies to develop how we measure choroidal thickness, because what they found is that there is a lot of variability. So this means that it is difficult in clinical practice to predict due to these very different variabilities of choroidal thickness. But it's something that we need to have on the lookout, because we know that choroidal thickness is important for myopia. And another study that I would like to highlight is this one that was looking at retinal biomarkers. So they looked into the foveal vascular zone and also into the superficial capillary plexus and the deep capillary plexus. So we can see that a lot of the retinal markers are also important in predicting AL and response to treatment. We may not be in a stage that we are able to have all the answers now, but we know that some of those are important. We just need to continue investigating better measures to have to monitor treatment, and ideally to have personalized treatment based on what we find, not only in terms of refraction, AL, but also in the response of the retina and the choroidal layer as well. So just to conclude my presentation, very important to do a risk assessment. So look at genetics, but also environment to determine the risk. Continue monitoring. If you can, take measures of AL and also, of course, refractive change, and try to intervene early. And most important of all of this, also try to spend some time. I know that the consultations need to be quick and there are patients waiting, but with other elements of the team, it's very important to do patient education, promote awareness, and explain the importance of compliance with the treatment. So thank you so much for the invitation, and I'm available for questions.
Well, thank you, Dr. Carla. You have explained in great detail about the evaluation and monitoring of this myopia. If I say that this is now turning into an epidemic in children because of the latest lifestyles and the different gadgets they are using, mobiles, all these things, so I will not be wrong. So during your discussion, you told us about monitoring. Dr. Carla, how much you can say that it is too much progressive progression of myopia, which is significant?
Okay, so that is very difficult to say. We don't have a universal value in terms of what is the cutoff for progression. But as I explained in my presentation, it is important to look into the normal growth or the amyotropic growth for that age. So it's very important to look at that and try to understand if it's above or below. And if we are talking about a child that is under progression or under treatment, then what we need to really understand is that, for example, when you introduce the treatment, if there is a reduction or stabilization, then it means that your treatment is at that point working. So I think that is also important. Look at the age, look at the normal or the amyotropic growth, and try to understand if the trajectory it's moving in the right direction. If it's moving in the right direction, so that's another factor that at least gives an information that the treatment is working.
Right. Dr. Karla, each and every visit, for example, you told us about my moderate and severe myopia and the frequent visits according to the severity. Every visit, should we do this cycloplegic refraction and the axial length measurement? What is your opinion about that?
I don't think we should do cycloplegic measurements in all of our appointments, but I think the baseline appointment is the most important, where we need an accurate definition of myopia. So I think that's important. If we have AL, then I think that monitoring with AL could be good after it. But of course, that and any time or any point in time, you have to change your management, or there is something that you need to because there is more progression, for example, then I would advise to repeat the cycloplegic refraction, because I think it's very important to have cycloplegic data and accurate data of the refractive error. So if you have the possibility of combining refraction with AL, then you can use those two together to help you, and you don't need to do cycloplegia at every appointment. But if you need to change, or if there is any change during the treatment, then I would advise to do cycloplegic refraction again. But I don't think there is a universal rule in terms of what to do. So this is just how to say, based on what I see from the clinicians, the experience of exchanging ideas, because in terms of research, we can only say that cycloplegic refraction is more accurate in determining the refractive error. And if we are talking about progression, then this may make the difference in terms of the final progression, when we are calculating how much the child progressed in 6 months or 1 year.
Right. Dr. Karna, we are also having nowadays different types of technologies and spectacles which are being claimed to prevent the progression using different technologies like dots and hearts. What is your experience about that?
Yeah, so I've worked in different countries such as Portugal and now here in the UAE, and we have most of the lens available, HAL technology and others, DIMS and CARE. Dots also, I've done a few analyses of the results of the study, but I must say that dot is the lens that I have less experience with. Because it's not available yet. So they seem to work in a different way, so more on the contrast function modulation. Although some of the studies comparing the spectacles, such as HAL and DIMS, also found that they may also work in a similar mechanism. We don't know yet properly how they work. We know that they are acting in the peripheral retina, but I think there is a lot still to discover in terms of the exact mechanism.
Right. Dr. Karla, for example, if we are managing, what are the trigger factors which we escalate our management protocols, especially in the children when we are managing myopia?
So yeah, so I think we need to escalate the protocol when we see that, for example, progression it's increasing, even when we have implemented our treatment. It is a treatment that has proven to be effective based on the evidence from the literature, and we know that the child is compliant. So very important to assess adherence, try to understand if the child is complying with the treatment, and check if there was any change in lifestyle as well. So if there wasn't a change in lifestyle and the child keeps progressing on the same treatment, then I think that's the time to consider to escalate and, for example, use combination therapy. So several studies have shown that using, for example, spectacle myopia control lenses together with atropine could be a good option for those cases of high risk of progression.
Thank you, Dr. Carla. And this we have talked about myopia, which are established cases and the progressing. What do you suggest about the pre-myops? How do we monitor those patients?
So I don't think at the moment we have a protocol to say that we should treat all the pre-myopes. So that's the discussion. Although there are several studies already showing that, for example, atropine, I think even red light therapy can delay the development of myopia in those children. Nevertheless, the question is whether should we treat them all. I don't think we are in the stage that we can say yes, but I would say that we are in the stage that we should advise following them properly in terms of recommendations and lifestyle changes. And what I said before, even if there is no myopia, explain very well to these parents that in future this could happen and what they need to do to uh, to avoid the development of myopia. And another thing that I must say is if we know the parents and child, or every parent and every child, it's very difficult for them to accept a treatment if they don't see a disease yet. So, and I think this is overall for the community, for our populations, we are not used to talk much about prevention and treat things that we don't see yet. So I think there's a lot of still a lot of work we can still do to try to understand if we can treat pre-myopes and how are we going to do and how the population, the parents and the child, how we are going to move into that direction. So it's I think it's still something that we need more research to be able to reply. But for sure, we need to do recommendations, lifestyle changes.
Right. And what about the red flags for the investigation about the secondary causes of myopia? What are these red flags you think?
Yeah. So that I receive a lot of other colleagues sometimes asking me what are the best methods for treating a high myope. And sometimes during the conversations, I can see that they are very young patients, they have very high myopia. So if you are in a situation that you have a patient that is very high myope, higher level of myopia than the age, then there's something that should prompt a red flag and should prompt for investigation of other diseases. Try to look into the retina to see if there is any dysfunction of the retina. Try to look for keratoconus, for example, or any other dysfunctions, and also investigate very well the history family to see if there is anything in the family that can help you or prompt you in the direction of identification of what could be. And I think I didn't approach this in the presentation, but the reason why we need to separate these children is because most of the studies where we are looking into myopia control methods are for environmental myopia or most school myopia. So we are not talking about genetic forms of myopia because on those we don't have much research to understand how those methods work. We have some groups that are studying the treatment of myopia progression in syndromic myopia, but we are still in the very initial stage of that part of the research.
Well, Dr. Carla, thank you very much for this very fruitful discussion. I know you are very busy with your international conferences, teaching sessions, patient management, and research. But whenever we invite you and to educate our audience, you always accept our invitation and to guide and teach our colleagues, patients, and parents. And I hope it will be very beneficial for them. And I want to thank you on the behalf of all of our audience and our colleagues. And we are looking forward to more educational sessions from you in future also. Thank you, Dr. Carla.
Thank you so much. I would just have to say thank you very much for your invitation. It's always a pleasure to participate, and I really like to help others to understand what research is saying and how we can improve our clinical practice. even if I'm busy, I'll try my best to continue to do and prepare these presentations, and I hope it's helpful for others that are seeing our interactions and our ideas and discussion about myopia. Thank you so much.
Thank you, Dr. Khan. Thank you.